Hello, I'm Melly Shansfeld, Managing Editor of Orthodontic Practice US, a MedMark publication. Welcome to a live presentation and question and answer with Dr. Moshiri, Dr. Alfred Griffin III, and Dr. Blake Davis. In our webinar today, we will be exploring how LightForce technology can help create an end-to-end digital practice and the importance of a streamlined system to help unite your orthodontic practice. You will also learn about LightForce's newest technology, Facemap. Before we get started, I would like to invite viewers to use the question box in your control panel to ask any questions, and your questions will be answered at the end of the session. Also associated with this presentation is a free CE quiz. At the end of the webinar, we will email all attendees instructions on how to access the CE quiz. I'm pleased to introduce our guest for today, Dr. Moshiri, Diplomate of the American Board of Orthodontics and Fellow in the American and International College of Dentists. Dr. Moshiri maintains his private practice in St. Louis, Missouri, alongside his father and sister. In addition to leading multiple Ask the Expert webinars, Dr. Moshiri was a lead educator for Class 2 kit solutions for Invisalign and the Deep Bite solutions of Invisalign G5. He's an assistant clinical professor at the St. Louis University Center for Advanced Dental Education, where he teaches with a clinical focus on the use of Invisalign. He's the founder of the Aligner Intensive Fellowship, a 17-week online course that teaches orthodontists how to properly treatment plan with aligners. Also joining us today is Dr. Alfred Griffin III, the co-founder and CEO of LightForce Orthodontics, a digital platform providing orthodontists with fully customized 3D printed tooth moving tools. Dr. Griffin received his Bachelor of Science in Biochemistry from the University of Virginia and completed his DMD and PhD in Craniofacial Biology at the Medical University of South Carolina in 2014. He earned his Master's of Medical Research and Certificate in Orthodontics from the Harvard School of Dental Medicine in 2017. In addition to leading LightForce, Dr. Griffin practices in the Boston area and serves on faculty as a lecturer in the Department of Developmental Biology at the Harvard School of Dental Medicine. Dr. Blake Davis specializes in treatment for children and adults. Dr. Davis completed dental school and his orthodontic residency program at the prestigious University of Washington. Since his graduation, Dr. Davis has demonstrated an incredible dedication to his practice and the profession of orthodontics. He's president of the Washington State Society of Orthodontics and lecturer at the University of Washington School of Dentistry. He's also a published author in orthodontic and dental peer-reviewed journals. Doctors, we turn the webinar over to you to learn more about our topic for today.
Hey everyone, my name is Alfred Griffin. I'm an orthodontist and the CEO and co-founder of LightForce Orthodontics. I'm very excited to introduce two incredible orthodontists and two incredible educators in the orthodontic space, Dr. Moshiri and Dr. Blake Davis, both of whom I've learned a ton from and have a lot of admiration for in how they think of digital orthodontics, digital office workflow, and applying the concepts of mass customization to the clinic. So very excited to welcome them both. Maybe just for everyone listening, I guess, where did you train? How'd you get into ortho? Quick minute on your background.
Yeah, so both my parents are specialists. My mom is an endodontist, my father's an orthodontist. So definitely, played a big role, I think, in terms of the path. And went to undergrad at Emory in Atlanta, Georgia, and then went to residency and dental school at Louisville, Kentucky. So did both dental school and residency there. And now I practice in St. Louis, Missouri with my father and sister. So it's been a journey and it's been great, and keep learning every day. So it's wonderful.
I actually didn't know. I knew your dad was an orthodontist. I did not know your mom was an endodontist.
Yeah.
Kind of at the opposites of the dental spectrum or specialty spectrum.
Complete opposites. And actually, when we started practicing, they were in the same office together. So we may have had the only endo-ortho practice in the United States.
I was going to say, I've heard of pedo-ortho, but never endo-ortho. That's new.
Yeah.
Cool. That's the other thing I just learned is my parents met in dental school. Is that where your parents met, I assume?
Yeah. So they met in Iran. Everyone was kind of grouped together. So you're in like the medical and dental students were together, and then you kind of decided your path. And so they met initially in the early onset of that, and then both went to dentistry. and then both came here to specialize and ended up getting married. And then the revolution broke out in Iran, and they couldn't go back, and they laid roots. So,
wow, that is cool. Blake, give us a little background on you. Where did you go to school? What's your journey? How'd you become an orthodontist? All that.
So I went to University of Washington. I did my dental training there as well as my orthodontic residency. Since graduating, for the most part, participated as a faculty member and now as an attending. I, for about 3.5 years, worked in the interdisciplinary clinic, the one that was founded by some of the names that you might know, the Spears, the Kokiches, et cetera, where you learn a lot, frankly, because it's a great place to work amongst other colleagues, other specialists. And so in the last 3-4 years now, I started up a practice in Kirkland, and now we have a second location in Redmond. So if you know where Microsoft is, we are right there next to what's been just a really cool area to practice in an area that really embraces all this technology. Like, I don't need to really explain what we're doing because they immediately know what's going on. And some of them actually know so much more than I do about the engineering process that they're explaining it to me, which is quite incredible, with 3D printing and the materials and everything like that. So it's been a really fun journey as we've kind of proceeded into full customization in our practice and a fully digital workflow, which is where I think everything needs to go. And I think most of us recognize that, not only for ourselves, but for our patients, right? That's the big thing. And so, yeah, it's been a fun journey.
You guys have obviously both been critical to the development of where we are today, in getting us to this point based on feedback. But, back in the earlier days, what was your aha moment where you made the decision, this is something that I want to invest my time in and help develop?
If you don't mind.
Yeah, go ahead.
Yeah, my aha moment was when I saw you in the first virtual AAO, to be really, really honest. It was so intuitive the moment I heard you talk that I, for months, maybe years, had been frustrated with my bracket system. I'd been using self-ligating brackets for 5-6 years. And I loved how we could take advantage of certain efficiencies with those, with variable torque and bracket position, things like that. But as soon as I finally heard someone say that we now have an option to customize the plan, basically customize the direction we want to go with treatment as opposed to the appliance, it was like, okay, now we're talking. And so I think as soon as we started to bond our patients, as soon as we started to see the expression occur so early on, and I think we all understand that planning with the end in mind is so powerful, not only for ourselves, but for our team. You guys were talking about the motivational factor with communication that it has. I mean, remember all the studies that we were doing with the AJODO for years, where they're looking at how to motivate patients to wear their headgear? I mean, isn't that crazy that now we're talking about how we can 3D map their face to motivate them to get the smile that they want? I mean, talk about such a revolution with what we're doing. So for me, I was immediately excited, but then of course, it has to deliver. And that meant bonding enough patients and seeing enough patients that for me, I was struggling with, patients where I was struggling to get torque expression, early even phase ones where I felt like I wasn't being the best orthodontist I could be. You guys probably recognize this too, where that patient comes in with lip incompetence, lip entrapment and the huge overjet, overbite. And we're sitting there saying, well, I don't want to throw a headgear on necessarily, but I also want to be able to treat this kid and eliminate the impingement. And so things like that are now treating out of my practice that I never thought, even a year ago was possible, was what has changed, everything for me.
Yeah. It's so funny. Like a lot of the big pivot in the industry is, thinking about, and Maz and I were just talking about this actually, this kind of patriarchal view of what patients should get versus now we're more thinking, all right, the modern consumer has options, inferior options, thinking about what's going through their mind, what is in it for them, what are they looking for? So that's an awesome point. Maz, what do you think? What was that moment when your aha moment?
I think it was really twofold. One, being able to take this process digital, because I was so used to it with aligners. I kind of yearned for it. with braces, but hadn't seen a solution yet that made sense to me. And yours totally did because of the amount of customization available to it, just like an aligner would offer, honestly. And then being able to eliminate a process from my office that I deemed as inefficient. You know, I knew that it was taxing for my lab technician to do indirect bonding. I knew it was taxing to carry different variable torques for my patients to be able to better treatment plan and customize their treatment, you know, with the analog process. So I think combining those two things really made all the sense in the world for me to transition over to doing LightForce and having a totally customizable digital solution for my patients. So that was, it was a no-brainer.
Yeah. I mean, I remember lectures from you 8 years ago talking about digital workflow in that process. So, I think that's also something patients appreciate is digital workflow where they're getting something that's going to be unique to them, whether it's a clear aligner or a fixed appliance, whatever that is, it's going to be specifically for them. So yeah, awesome.
Something I haven't talked about yet either, just one thing we've noticed, I'm not sure if you guys were doing this. We used to only bond one arch at a time. That was our preference. And we used to put top braces on because we had so much OHI and instruction, and then the doctor time to put on 2 arches. I mean, I know offices that do that very well, but we weren't. And LightForce has eliminated 1 whole hour appointment from our schedule every time we bond the patient from what we were doing historically, if I was not doing indirect bonding on that patient. Because to be really an indirect bond candidate in our office, we had to really wait for the dentition to be in, and now we find ourselves waiting to make sure they're indirect bonding candidates because we see the efficiencies associated with it. So.
Enabled by the turbos?
Enabled by the turbos, but also just, I think, in terms of what we were doing, we're waiting now a little bit longer, because, if you focus on treatment times, for example, and look back at things, sometimes I was waiting for, second molars to come in and the patient was in treatment too long. So now I'm just like, you know what, we're just going to see them back in 6 months. And I want to make sure they're indirect bonding candidates. And that way we know we're going to get in and get out of treatment as fast as possible. So I've kind of changed a little bit of my thinking of how I'm starting patients so I can make sure they're indirect bonding candidates versus doing like a direct bond. And you're like, I'll pick them up later, right? Yeah. But I'm trying to get away from that as much as I can because I'd rather indirect bond people. So
probably what the patient wants as well, having braces on for as short a time as possible. Most
Absolutely.
patients. Yeah.
Absolutely. So.
Cool.
We used to bond single arches as well for that very reason, just efficiencies in the clinic. The other thing I would add there is that for our patients who want to get started the day that they come in for their exam, it's been really nice rather than scrambling in the clinic to grab, your upper arch stock brackets. Now you're just scanning. And that again aligns with our clear aligner system that we have in our practice with getting patients started. So it's freed us up so much to get patients going in the practice and helped us grow because of that as well. So that's been a huge, huge bonus for us.
Awesome. Yeah, that was I give my dad some credit. He was like, can you guys, make me a bite turbo that opens it up the right amount? I was like, not a bad idea. So that's where that kind of came from. And I've been doing the same. Like one of the things early on, before we had a lot of the features we have today is, you wait, or you'd want to do a upper arch first, then a lower arch. And your big concern would be like, even for really big deep bites, you couldn't avoid hitting the lower brackets. And I hate freehanding bite turbos in the back because you either open them up too much, it's uncomfortable, or you got to file them down to be exactly right. And they never really feel great. So that's for sure enabled me to do more.
I have a crazy deep bite that I'm so excited to show you.
Oh, okay. Excellent.
Crazy deep bite. She's almost done.
That's fantastic.
She's been in treatment. She's been in treatment less than, or it's going to be about a year total when she's done. Adult deep bite.
The power of disclusion, Maz. I mean, that's
awesome.
They move faster, but it's also functional. You're intruding lower incisors as well, and
I'm excited to show it to you guys. So
I can't wait.
Cool.
As someone who's been, lecturing on aligners for many, many years. Actually, I just did a ClinCheck the other day, opening up ClinCheck, and you're one of the first faces I see when I open ClinCheck. So clearly, what's going on in the aligner world. How does something like LightForce fit into your practice?
Well, prior to LightForce, our entire bracket and wire system was really analog. So when you're treating about 50% of your patients with aligners and you're used to that workflow, and then you're doing 50% analog, there's just a little bit of a disconnect there. I would prefer a digital workflow, honestly, in terms of what I'm doing. It doesn't demand me being chairside as much, and it doesn't mean I'm not diagnosing or just as involved, because that's obviously more front-end oriented on the computer. It's just a different way of doing things. But since integrating LightForce, it's been awesome to be able to leverage the technology in terms of not only diagnosis, in terms of what I'm seeing. And I know we'll probably talk about the smile arc and face mapping later, but being able to really set the case up with that in mind, give my instructions to the LightForce technician, or integrate findings I have on the CEF for the custom prescription I want, combining that again with what I want with the smile, with the goals of treatment. And then just being able to approve the light plan, and then I don't have to see the patient again from all the wires and oral hygiene instructions were given chairside, and I come by and check on them and make sure that they don't have any questions for me. So it allows me to use my time more efficiently, be it if I need to be at a computer or be it in consultation. We've been slammed this year since coming back. I think across nationally, offices are very, very busy right now. And so that's kind of been a blessing that we kind of started that journey with LightForce, and we're able to leverage that now appropriately to give myself a little more time back with regards to where my doctor time is most needed. So
yeah. There's a huge difference between an analog workflow and a digital workflow, as you know, and so that's, I think, been the toughest thing for a lot of doctors to reconcile in their practice. The workflow of the patients, and then just also the clinical mindset. One of the things I've heard you say in your lectures for many years now is, when you're moving teeth on a computer screen, you're moving, vectors of torque. And so you've got, some of your patients are treated that way digitally, and then others are done analog, where essentially what it is freehanding. Freehanding, a stock bracket placement versus something that's very precise, either with, aligners or LightForce. I think that's going to be one of the biggest challenges for the industry to change, is making that big jump to being digital, and the change in clinical philosophy, where you're, instead of looking at a mirror, using a mirror and articulating paper, you're now looking at software, looking at occlusal contacts, how hard they are, how light they are, and vectors of force, depending on the appliance you're going to use.
I was just speaking to the technicians at LightForce in terms of, I think, some preferences I had, because you are looking at vectors of force. You're designing a force system in the software, so it's not an apples to apples outcome. What you see in LightForce is not what you're going to necessarily get clinically. It's the same with Invisalign or whatever aligner system you're using. You're designing a force system, so there's going to be some overcompensations you need to make, or some exaggerations, or over engineering, or over treatment, however you want to describe it, just like you would if you're using an analog process to some extent. Like if you had an extraction space closure, you may add a gable bend with your bracket placement to get more root parallelism, right? But those things are being automated now in terms of what we're trying to do within the digital workflow. So if I have certain things that, if I have a class 3 patient and I want to have high torque upper, low torque lower, to keep the case compensated. For example, if I'm not doing jaw surgery, how do you build that in the software? And those nuances we've all come to understand over time from getting used to how we treat patients with aligners. But we were doing that in our analog process to some extent because I had custom variable torques, but I had this whole inventory of brackets that I would have for patients, right? Well, now it's all in one place in the cloud, if you will, where when I have that type of patient, it's all right there for me. I no longer have to keep an inventory. And to be frank, the bracket I was using was being discontinued from 3M. I was using smart clip braces that we had those custom torques, and not having that available to me, I had to make a transition. And this was just an easy transition because I'm already used to the digital workflow concept of things, and being able to have all those, customizations online and the automation of things is beautiful. So it's seamlessly integrated. It wasn't this huge, like, oh my God, I have to learn this whole new bracket, right? It was just, it seamlessly integrated right into our workflow. So that was great.
The patient comes into the TC room. What goes through your mind in making that decision now that you're using LightForce in terms of what's best for the patient? Because everyone has to say clear aligner patient, LightForce patient, or sock braces patient, whatever you use. I guess what are some of the checklist things that go through your mind when you're making that decision for the patient in guiding them?
Yeah, absolutely. I think that probably just like any orthodontist who would listen to this, you're going to look at the photos at the outset. You're going to already start thinking about in your mind what treatment options are. We go in, we look, we do an evaluation and make the diagnosis. And then at that point, I'm really thinking about, are there any limiting factors, right? When we're thinking about clear aligners, there's certain things that just is really challenging with, multiple complex movements, rotations, vertical movements, things like that. And so we're immediately thinking at that point, okay, what are the limitations to the case? But then I take it beyond that, because in our practice, what we try to focus on a lot is the lifestyle. So we actually ask questions in advance, lifestyle type questions, in advance about what's going to be best for them during this process. And so we talk a lot about knowing yourself. And for some patients, frankly, wearing something removable isn't the best option for them. So if I feel like we can achieve the same result, let's say, with either clear aligners or with LightForce, then what we're thinking is that we just need to talk about what's going to be best for them in that case. As you know very well, in many situations, especially if you're trying to get very specific movements for teeth, we might need to use fixed appliances. And those are the cases where I now have the freedom, especially as we're talking about translucent braces, for our patients to actually make a apples to apples decision. It's no longer apples to oranges. It's apples to apples, because we now have a discrete option, whether it's braces or whether it's clear aligners. And so then realistically, we get to just have fun and talk about what's best for our patients in these situations.
Yeah. So Maz, you've been in the industry for many years. You've been approached by a bunch of companies. What is it like to work with a company that can listen to feedback and make changes at a pace like that?
Well, it's great because you don't feel like you're stuck. I mean, there's no perfect appliance. Everything can use improvement. But to that end, when you're a clinician, you see something wrong, to have to wait a year or whatever it is to see that innovation come around can be very frustrating, because you have to then deal with the issue in real time yourself on a day-to-day basis. So any recommendation I've made to you guys, you've like, hey, great idea, let's go talk to the engineers about it. And then you'll ping me back like, hey, we're changing it, we're doing it. And it's just like, what? Like that took like a month. Like how'd that even happen, so quickly? But it's just crazy. But still, it's pretty remarkable, the speed of which you can innovate and change, given, I think, the complexities of what are involved, or historically what we're used to in terms of norms. It's totally different. So it's really cool. It's really cool.
The flip side of that is having people like you and orthodontists who are so engaged. When we bring, our goal is to build the best engineering team in the industry. And a lot of them didn't come from the orthodontics industry. A lot of them came from the 3D printing space or some other technology and or CAD space. And they're not used to having a user base who is so engaged in the product. And so when you ask them what the favorite part about their job is, the engineering team here at LightForce, is that they have such engagement from the users. That's how you learn. That's what every engineer wants, is for someone to be using what you do and to be very excited about it. That's fuel for them. That's what's
cool is I think orthodontists are kind of like engineers in many ways. So to be able to kind of have those conversations, we love biomechanics. We love getting into the nitty gritty of things and, seeing how things work, so it's great.
Talk about, so obviously you're an orthodontist, but you're also a practice owner. You've got a location in Redmond and Kirkland, correct? Yeah.
Correct.
So you're also essentially the CEO of your business. How do you think of digital tools like LightForce in terms of running a business? What are the considerations?
Well, I think we can step back years to when clear aligners, came out, right? Everyone was concerned about lab costs up front, all the cost of the scanners and the new technology. And then I think as you do more and you make it a more efficient process and a better process for your patients, I think then all of a sudden it frees you up more than you may have realized. And so what's happened is, for us, I didn't realize this was going to happen like it had happened in some ways for us with aligners. But as soon as we started using 3D printed brackets and aligning our systems like we talked about before, where everything's fully digital, we've actually been able to see a lot more patients in our practice. We've been able to see them in a way that's more convenient with their schedule, which immediately starts to push people in the community to recommend your practice, which has been a built-in marketing stream of people who are like, hey, where'd those white brackets come from? We want to go see you. So we get people frequently who are self-referred now just for the 3D printed brackets in our area, which is pretty cool. I mean, if that doesn't bring a smile to your face, I don't know what will, as a business owner, right? And so, then when we're looking at this, as far as just cost effectiveness, seeing your patients in a 3-4 month, sometimes 5-month interval, is really, really beneficial, of course, not only for them, but also for the cost per visit. And I think when you start to boil things down, and as we'll go further with this and we'll get enough, finished cases where this can be really evaluated with a sample size that's adequate to compare. But I think what people will start to see is that this might be even more efficient than what we're seeing with clear aligners, meaning with what we're paying up front and what the auxiliary costs are and everything like that to go into delivering care. I think we might find that this is actually a better price point per visit than even what we're seeing with aligners. And so as you do enough of this, what's happening is it's just allowing your practice to grow. And if that's what you want, and I think most orthodontists want a certain level of growth, or at least just consistency, that's kind of what you'll expect to see. And so it's been wonderful. I think the pain point, of course, is just the commitment and jumping in the deep end. And I think people are understanding of that, that is realistically what's hard, is just taking that first step and then leaping. But once you leap, I don't think you go back. Like I had a day where, this was a few weeks ago, where I bonded, I think 3 or 4 patients with stock brackets. And I came home to my wife and I was like, man, I haven't worked that hard in months. Like, I was like, whoa, I don't know if I can continue to do this way, because I've been so spoiled, which sounds ridiculous. But with that said, it is so nice to be the one making critical decisions for your patients, thinking about their best possible care, and freeing you up to think about all the things we want to think about. You said we're engineers. We are. We love the mechanics, the art, all these things that really drove us into this position. And so now we're doing those things. I mean, you can relate to this. I mean, it's no fun when you're sitting there with a teenager just focused on just how they're wearing their rubber bands or getting that one tooth into the right position for the occlusion. Now we're thinking more about like, okay, how do we perfect the smile? Because we already had the occlusion 6 months ago. And so, that truly is what is changing our practice. And, I gave a lecture a month or 2 ago to a group of pediatric dentists. And one of the coolest things that came out of that was that after I spoke, we talked about all the newest modern technology. I received messages from a number of them, even a letter talking about how inspired they were for the future of orthodontics. And, that doesn't happen every day. If I go and, drop off my braces that I have in my closet right now, they're not going to get that excited. They see plaque all over that all day long. But, at this point, I think what's cool is that we are really changing the face of what we're doing. And it's fun to be part of that evolution.
Yeah, it's cool. I think you mentioned a few great points there. Regardless of the patient, like they've got like a finite time that I feel like mentally they're willing to commit to treatment.
Yeah.
And this is true of, any tool you use, whether it's aligners, braces, LightForce, whatever. So you want to get them in and out. Like you can't ask them to wear class 2 elastics for 3 years. Like it's not going to happen. So you want to maximize the time that you have there mentally. There's a patient engagement component to what we do as well.
Absolutely. I always tell my team it's like 12 to 14 months with adults. Mm-hmm. And I think maybe we have 14 to 18 with teenagers, right?
Yeah.
Sometimes the best patients are the phase 1 patients who are just so excited to see you every time they're in, right?
Right.
Which is what makes it so cool. But yeah, it is. There is that threshold point where they kind of fatigue. And, if we're asking them to still be doing the hardest parts of treatment, like class 2 correction, it's probably not going to turn out the way any of us want to.
Yeah. Yeah, totally. Totally. One of the reasons we place so much emphasis on the indirect bonding process is that it's an absolute linchpin for what we do. Did you have any experience indirect bonding stock braces before?
Yes. I mean, our whole workflow was scan. Well, let me take you through the history, I guess. It was, taking the impression, pouring it up and then putting the braces on the model and so on and so forth. And then we transitioned to scan, 3D print, braces on the model, but it was all done by hand still in terms of the bracket placement. So the lab technician would place the brackets initially, doctor would fine tune in detail. We were transferring the black case back from the lab to the doctor, back to the lab from the doctor. And that's an arduous process on the lab technician. So again, I think I was telling you my lab was getting overwhelmed. I've completely taken the indirect bonding off her table, right? I've taken like our RPEs, the Hyrexes off of her table. So she only makes like acrylic appliances now in-house, which is very easy for her to do, or in-house aligners at times. Which again, if it gets to be too much, I can outsource it very easily to Invisalign or to ULab or whatever I want to use. So just having the ability to outsource those things and to be able to have a digital workflow has been truly incredible. So
have you noticed any difference in terms of bond strength and or emergencies with the old? I guess I take a step back. What are some of the biggest differences you've seen between indirect bonding stock braces and fully custom braces?
Well, outside of the inefficiencies of the workflow, which are significant, right, in terms of just the lab time and doctor time doing everything by hand. I think the actual process itself, the jigs are beautiful that come in. They seat very easily. The way they're sectioned, it's I don't want to say it's idiot proof because certainly things can go wrong. It's any bonding process is technique sensitive, but being able to actually seat the trays is very easy. The assistants, I've had some, obviously, and every office has this. Some assistants really need good training. Other ones that are experienced, they just learn it immediately. But the first assistant I had was my best indirect bonding. She did her bonding half the amount of time with the LightForce jigs than she does with our normal jigs that we were using forever. And she just said this was much easier than our normal indirect bonding process. And it's just, we had some training with it, obviously, and we continue to train because we want to get better and better on a day-to-day basis. But it's been much easier to bond those jigs in terms of clinical chair time than it is our old templates. So it's been a nice transition.
Have you ever had any of those brackets that kind of from LightForce that you look at and like, that's kind of an interesting position, or that, is
that was,
exactly.
Yeah, that was mind bending for my sister because like she didn't. I'm the one that kind of really jumped into LightForce, and she thought we placed the bracket incorrectly. She was like, that doesn't look right, and it's like, well, no, it's the base is changing based on the position of the tooth. It's not the bracket position changing based on the position of the tooth, which is, you're not used to seeing things the same way. Because then it was like, well, what if this bracket breaks? Can I just rebond it wherever I want? I'm like, no. You gotta put it exactly where it was made. It's a very specific placement. It's meant to set it and forget it, meaning that you bond it, put your wire in, let the wire bake out. Obviously you have to still run your anchorage, IPR, all those things that you would need to do diagnostically speaking, but the position of the bracket is the position of the bracket. It's where it's supposed to be, and it's in the perfect position. And it takes into account custom tip torque, and in and out to get the tooth where you want it to be on a digital treatment plan.
Have you seen a reduction at all in rebonds, maybe where you have like a tooth that's blocked out partially or rotated or crowded, and where you see like you bond a LightForce bracket, more mesally or distally, and then just kind of leave it there?
We haven't done that yet.
Okay. All right.
We haven't had to do that. We haven't rebonded a bracket.
Rebond, no. Oh, sorry. Take a step back. I mean, like, sometimes you have like maybe the mesial of a incisor is blocked out, and you have to bond a bracket on the distal.
No, I know what you're saying.
Oh, yeah, yeah.
I'm saying that that's eliminating
You
to
just
do that.
Yeah.
Yeah. Yeah.
Okay, all right, good. That's one of the big things I've noticed comparison to old indirect bonding technologies. When you're putting a stock bracket on, it's got to be in the middle of the tooth, right?
Yeah. For the most part. Yeah.
Most part, yeah, and or you compensate with a rotation bend later or something like that.
Yeah, I think the only thing I can think of is like, obviously if it's a situation where you just cannot get a bracket on the tooth. I mean, there's instances where there's so much crowding, open cold, spring bursts and so forth. I mean, but that's, there's no solution to that otherwise. But no, placing the bracket, if you need, for example, a distal out and your bracket's on the mesial, like you're saying, you're not going to get that couple or that moment you need. But the way the base is oriented, you can place it anywhere on the tooth, but it's custom milled. So you're going to get the forces needed to spin the tooth around. So it's pretty cool to see that, and to be able to leverage that.
Yeah, totally. That's been a big point of emphasis, is making indirect bonding more scalable within your practice. And if you have to rebond a bracket on FA point, move it over later labally or something or like that. Sorry again. That's been a big point of emphasis for us at LightForce, is making indirect bonding scalable, where by virtue of the fact that you have a fully custom base, you can actually put the bracket more mesial or more distal to avoid your staff having to get out the bonding equipment later on at appointment 3, 4, or whatever.
Sure.
Okay. So we're taking questions from the audience now. And the first question is about the white bracket. So it's a great question. Obviously, the industry has not seen a whole lot of white brackets. Dr. Davis, what has been your experience with patient perception of a white bracket versus a metal or translucent one?
I think we've been programmed into thinking that metal or silver is normal, right? But what I think I've found personally is that people are willing to change and modify their perception of what they should have if it means they get a better product and better technology. And so there was a little pushback at first, I think mostly because people were unsure. They'd seen all their friends in the community with metal brackets or sometimes some of the ceramic brackets. And they were uncertain what this was. This is white. What's going to happen? Is it going to stain? Or are we going to have problems? Fortunately, we haven't had any of those. And actually now at this point, we have people who come in asking for the white bracket, which has been great. And so I think the advantages with the white bracket are that kids in particular have the option to really pop colors. It is a little bit more streamlined as you're looking at it. And of course, it's something unique. And in this day and age where everyone's so focused on things, personalized, really customized product. I mean, look at any part of our lives right now. It's all custom. They want something different and they want to be cool and have fun with it. And so in our area, it's really resonated. It's been great. We had really the pushback, I think, came from the team. And so once you get past that yourself, I think it's like, well, why else would I want anything else, right? I often have that happen and occur in the exam where I go through, we still have some of our stock brackets sitting there on typodonts. And by the time I've talked about things, they look at me and say, well, why wouldn't I want those ones? And I'm kind of like, yeah, you're right. You don't want anything else. So I think from that standpoint, it's more about just converting and changing your mindset in your practice.
Yeah. Yeah. Thinking about what the patient wants versus what our pattern recognition might be.
Yes.
It's a good point. I guess what demographic would you say the white bracket appeals most to?
I would say right now in our practice, we have the phase 1 patients that love it because of the colors. As soon as we introduced that into our interceptive treatment plan, it was a hit, and to the point where it's almost all kids at that age choose now. As far as the teenagers, I think from their standpoint, most still like the white bracket, the cloud bracket. There has been some of that transition to other options like the translucent. And then even with adults, it's funny because we treat a lot of adults in my practice. Once I went through the technology, the why, we have so many adults, Alfred, walking around right now with white brackets, that, I think for most of their standpoints, it was more about what's going to get me the best outcome, not so much, what does this look like? And then secondarily, they come back and they're like, oh, actually, I kind of like these. They look good. It looks really nice. It's actually making things look more uniform and white. So, I don't think it's been a huge barrier, but definitely those phase 1 kids love the white bracket.
Yeah. Give the patients what they want.
Yeah.
Cool. So, next question is about business economics. So we have options. You can get braces pretty cheap these days. So as the CEO of your practice, how did you go through the economics of making the decision to start using something like LightForce?
Yeah, I just used the same model I've been using with my clear aligners. In fact, the way I look at it, the price point is actually even better when you look at LightForce, because obviously the price point isn't as high, but what we're finding is, as far as efficiencies within the practice, efficiencies within treating our patients, I think we may actually be even a little bit better than we have been with our clear aligners. I think our average clear aligner time is about 12 to 14 months in treatment. I think what we're projecting right now, even though we haven't finished a lot of cases with LightForce, I think we're projecting somewhere similar right now. Most of our cases are finishing up around, or nearing finishing up around 9, 10, 11 months. And so, I know that's a sticking point for a lot of people. I just think, though, that just like anything, if you want to deliver the best possible care and then think about the efficiencies, which is why I think most of us have jumped into the world of LightForce, it's because we want to deliver, like we said, that kind of care where they're coming in every 3, 4, 5 months. But also, when we think about how many days then that means we need to have clinical availability in our practice, that means less time that we need to carve out, because we're not seeing them every 4 weeks, even every 6 or 8.
Yeah. It totally makes sense. What I see in a lot of other industries in medicine is, doctors working at the top of their credentials, and you're the most expensive person in your practice. So, factoring in your costs is a big part of that overhead for
Yeah. Yeah. An interesting thing, Alfred, too, and hopefully this is okay just to keep going on about this, but, one of the concerns with delegating these things in the practice was that there was going to be less one-on-one time with myself and the patients. And actually what I found is, because I'm the one doing all the light plans, I'm working through their care up front, I actually feel like I have more of a connection. I'll walk up to them and say, hey, how's that upper right 5 doing right now? 6 months into treatment, because I know exactly and thought through exactly what needed to happen for these cases to play out the right way. And so actually it's been really funny, because we've got more of a response from our patients that's been positive about the doctor engagement than anything. And so I was really, again, that was a big concern of mine, was that, people come in because they want to see the doctor. And if I'm not the one putting on the braces, is that a problem? But if anything, it's given me much more time to engage with our parents, explain our adults, or explain the process to our adults, and just have fun and joke around in the clinic, because, I'm freed up a little bit more because of it.
So one of the questions is, how does LightForce stand out from other custom appliances, and how is it different? The big reason is that LightForce is the only fully custom bracket made in the world. It's the only one that has both a fully custom base and slot. So if you think of, drill down to what a bracket is, it's a connector from a tooth to a wire. What LightForce does is it perfectly matches the anatomy of the tooth and the exact angulation where the slot needs to be according to the setup to engage the slot in terms of torque tip, all the prescriptions of a bracket. So that didn't exist until now, and it's only enabled by 3D printing. So that's what really separates it as a bracket specifically. As a system, there are other tools that are custom to that patient, such as bite turbos. There's some different nuances and algorithms in the tray that are also enabled by 3D printed custom brackets. So there are a lot of technologies put into an overall system. But to boil it down to the most basic point to answer the question is that it is the first fully custom bracket, and it's 3D printed. That's what makes it very unique. Do I have to keep an inventory of brackets with LightForce? No. Simple answer, no. Everything is on demand. Every case, and you couldn't really, because every bracket is unique to the patient. We've never made the same bracket. So every case ships with brackets preloaded into the indirect bonding tray so that there's no loading. You just put paste in the back and cement them. And then there's a backup set of brackets for those exact teeth shipped with every case as well. And there, if you need to reorder brackets beyond that, which is very rare, that's available at no charge. But there's no inventory. Wouldn't make sense for a custom bracket. How can LightForce benefit my staff? So what I can speak anecdotally myself, and I can speak for what I've heard from other orthodontists. But in general, it's engaging for the staff. Anytime a staff can do more, they enjoy that. That's one of the reasons assistants prefer orthodontics versus general dentistry, because they get to do more. There's more patient engagement versus just suctioning. So when an assistant can legally bond a case for you, that's a lot more than they can currently do today. So in my practice, it's been a motivator for my staff. It's been giving them more autonomy, more empowerment, and that's what we've been seeing across the nation from doctors. It's been empowering and engaging for their staff. How are LightForce's indirect bonding trays different from what's on the market? So to start with the tray itself, great question. There are many algorithms that go into this tray that haven't existed before. And basically what we did is we sat down with some of the smartest engineers in the world and said, here are the problems we deal with today with indirect bonding. Can you fix them? So, pulling trays off and having them tear, or not having them have a great path to draw to take off. Errors. Historically, we'd have to put labial pressure against the bracket. So these trays have another level of customization to them for the anatomy of the patient that make them scalable for your staff. We take an Apple approach to product development to really make the user experience very simplistic. The other thing I would say is that we leverage the fact that we're indirect bonding fully custom brackets, which is a big deal because that means that the base is going to match the tooth anatomy exactly. So just by taking all the little paper cuts of inaccuracy out of the indirect bonding process enables us to deliver a much more reliable, precise indirect bonding experience for your staff, for your patients, for you. How does Facemap work, and what do I need to use it? Great question. So Facemap, for those of you who haven't had exposure to it yet, is basically 3D mapping the entire patient's face and then stitching that onto the patient's scanned dentition. And then using the face on the light plan as a reference point for the upper anteriors to dial in the smile arc exactly. So all you need to use Facemap is an iOS device. That can be an iPad, iPhone. I believe it's iPhone 10 or higher. And I'm not sure what it is for iPads, but basically that's what it is. It's very simple. And then you can turn it on or off within LightPlan to help you diagnose smile arc. And then I use it as well as a tool for patient engagement. So before I bond the patient, I show them the screen. I show them, this is your case. And they know it's their case because they can see their face. They're like, yes, this is for me. That's my face. This is where we want to end up from a smile arc point of view. This is the smile we want to leave you with. And this is how we're going to get there. And then we show them the animation of the teeth moving. And what I've seen is that's been very engaging for patients. The proof is oftentimes when I show this to the sons and daughters of parents, the parents actually end up in treatment shortly after as well. So I see it both as a diagnostic tool and as a patient engagement tool. How have patients reacted to Facemap? Do they like it? Yes, they like it. As I just mentioned, it's been an engagement tool. It's brought them into treatment, helped them understand how the teeth are going to move. It's also helped emphasize the fact that this is a custom treatment only for them, and they get that because not everyone recognizes their teeth, but everyone recognizes their face. When they see their face on top of their teeth, it becomes very clear, this is just for me to optimize my smile, to optimize my bite. When can I use Facemap? Great question. Currently, it is only available to existing LightForce users, but we expect to roll that out to everyone at AAO this year in Boston. So we look forward to seeing you then.
All right, so we've been having a lot of fun in our practice with LightForce. It's been a great addition for many reasons, but most of all, it's really allowed our team, myself, to work together better than ever. And so what I want to do today is I want to show you a few different cases. We'll show a real straightforward one that's a little bit more complex, and then one that kind of looks into the future of what we're now doing in our practice and how we're taking advantage of the custom appliance and the digital setup. So let's start here today. This is Miles. And so for Miles, we're going to go right to his setup. And so for Miles, as you can see, he has class 1 anterior crossbite. This is what's really great about having the setup like this. I can actually grab it, move it around, really do probably a better diagnosis than I would in the exam room, which really helps as we're trying to plan care. And so you can see again here, the buccal segments, anterior. I'll show you the occlusal here in the maxilla, and then as well in the mandible. And so we have some crowding, we have the crossbite. And so what we're going to do is we're going to go ahead and start by adding the brackets. And so I'm going to put the brackets on. You can see here, if we're going to add brackets in one appointment, we're definitely going to need to open the bite up. So we're going to add the anterior bite turbos, as you can see right there. So these are custom turbos. This is something that really allows us to exclude the occlusion, but also avoid some of the issues that I've experienced with the metal bite turbos in the past, or even the bondable bite turbos, because with this, they are customized to get just a small space between brackets and the opposing teeth. And so that's really been great for our patients as well, because as you see in the cases that we're going to show, it really allows them to more freely align the teeth. And so here we go. We're going to go ahead and add the arch wire. And as you can see, we're going to map out what our final plan should be. And so this is where then we want to place Miles. And you'll notice how when we're looking at the prescription that I've created in the brackets themselves, you'll notice that I have a different torque here on the upper left relative to the upper right. Really, one of the biggest challenges that we see is root control as we're aligning, leveling, and finishing these teeth that are starting cross bites. And so for me, I want to make sure that we get great root control. And that's why we built it into the bracket. And that's something I could never really do very well with my stock brackets. So let's go ahead and show exactly what we want to expect. Again, this is great because now I'm instructing my team exactly how we want to go through this process. We have a blueprint for exactly what we want to do. You can see here from the occlusal view exactly how we want to approach alignment. And so let's go ahead and shoot back to Miles. And you can see now within the first 4 months where he's at. And so just like we talked about the fact that we had a plan in mind and how we wanted to move the teeth, and excluding in the anterior, as you can see, has really, really helped. And so what it's allowed us to do is already eliminate the anterior crossbite. We've essentially aligned the arches at this point. This is only 4 months into treatment. And also you're starting to see as I get into a final finishing wire, for him, I think this is going to end up being a NiTi. And we've engaged the edgewise slot there. What we want to do is we want to make sure, again, that we get a good root position for that tooth. And so that's something that we'll want to monitor as we finish Miles up. But again, great case to show within 4 months how customization allows us to move so quickly through treatment. So we're on to case number 2. So this is a fun complex adult treatment. And the reason I want to show this is because I think for anyone who currently is directly bonding in their office, they can appreciate how challenging it would be to accurately and properly place brackets. And so we've talked about it many times, but this is a real strength of the LightForce system, is the custom transfer trays. And so I'm going to walk through this and just talk a little bit about how bonding the brackets in the right position and not really having to worry about their position helps us to efficiently move the teeth, because really then it frees us up to think more about the biomechanics of the case. So let's go ahead and dive right now into our digital setup. So of course, what we're thinking about initially is we're thinking about diagnosis. And so we can really appreciate the anterior crossbite here and the anterior crowding. But for some background, the patient is bimax protrusive and actually skeletally orthognathic. And so our treatment plan was to extract 4 first premolars. So that's what we have here. And that's what you can see in the setup. Premolars are gone. I did this, the extraction that is after brackets were bonded. That way, when we scan teeth and start shifting around, and we were able to transfer things accurately. But just like anything with LightForce, and we want to approach things with the end in mind. And so let's go to the final tooth position. So this is my setup of where I want the teeth in their final position. We're going to go ahead and place the brackets and the arch wire. And then I'm going to go ahead and just animate how we want to move the teeth. And what you'll appreciate here and recognize probably is how, when we're looking at the movement of the teeth, we're retracting these canine teeth directly into the position where those teeth were extracted. And then to alleviate the proclination on the lower anterior, we're just retracting that anterior segment as we're also aligning. And so when we look at this case, we can go ahead and look at how the teeth really should be moving in their sequence. And what you'll recognize here is just early retraction of our canines. At that point, we're able to start moving the laterals into position once they get a little bit more space. And so what I'm going to do is move us over to the treatment sequence so you can see exactly how this played out. So here we are initially. This is where the patient started and presented. And then this is when we first put on the brackets with indirect bonding and extracted teeth. And so he came back. We went ahead and started using some of the mechanics that we had planned and outlined for his treatment. And so what that meant was getting into an edgewise copper niti in the upper arch initially. This is a light niti in the lower arch, round arch wire. So we went ahead and started retracting canines just like we talked about and planned. Second step was to start using open coils to make room for those laterals so that then the following visits, we could go ahead and engage those teeth. You can go ahead and see from above here on the occlusal maxillary view, we took out those teeth, started retracting, went ahead and made room, and then, as you can see here, started to engage the laterals once we had space. And so here we are in about 6 months of treatment time. I have seen him more frequently in this case just because I wanted to continue space closure. You could potentially argue in this case that you would use something like niti closing springs. I did disclude, you can see the bite turbos in the posterior. I didn't want to do that. I didn't want to use anterior bite turbos in this case, although we could have designed them to go on the lower incisors, because at that point we were also doing a lot of alignment of the lower anterior teeth, and I didn't want to have any issues during alignment that might affect perio health or retraction. And so I would expect at our next visit, we are going to be able to get into a edgewise niti and continue to retract and have a great arch form at this point. Despite the complexity of this case, one of the real advantages of using our digital workflow here is that we were able to keep in mind where we want to position the teeth at the very end of treatment. And so what you'll recognize is that even throughout this entire process, I was able to focus on where I want those front teeth. And so again, you can see we're positioning those in a position that is best for the patient facially. And this is really the advantage of doing things digitally. When I first jumped on the video, I kind of threw out the teaser about the future of my practice.
And I think it's the future of everyone's practice, because inevitably we all want better treatment, better care for our patients. And I think as we focus more on diagnosis beyond just the teeth, I think we start to recognize how, the facial aesthetics, skeletal balance and harmony factor so much into getting the best possible result for our patients. And so I felt like this was a really good case to showcase something that LightForce is doing now to help us model patients' treatment based upon facial aesthetics. And so this is Ben. He's a teenager, and actually his biggest concern presenting is just the fact that those front teeth are rotated and he's not showing much of his upper teeth. He doesn't like that they look so flared and flat with his smile. And so I thought that was a pretty astute observation, because he's exactly right. And that really is the problem that we see here with his presentation. And so what we want to do for Ben is we want to find a way to not only retract those teeth that are currently flared, but also improve his smile arc. And so when we look at his lateral ceph, what you can see here is I've drawn a line to the point where we want to create this occlusal plane that fits there, so that when we're looking at the smile, and this is something I'm sure you guys have all used a lot, is looking at where the lips at rest would be relative to the upper lip. And so often, to get that tooth incisal edge into the right position, we want to see about 2 to 3 millimeters of the incisal edge at lips to rest. And so this is kind of what I've approximated here on the lateral ceph. When we go to the digital setup, what you can really appreciate here is how he almost has a reverse smile arc. And so again, this is something that is really, really cool that we're now doing in our practice thanks to LightForce. We are scanning patients facially. So let me just show you here as we zoom out. This is Ben. And right now, we'll tip his head into a little bit better position. This is how he smiles, and this is what it looks like as we're evaluating and diagnosing. And so what we want to do is, again, think about where we want these teeth positioned at the very end of treatment. And so we're going to design his treatment based upon that. And so we're going to start by using the facial reference points as our indicators for where we want to move the teeth. And so let's go ahead and show how we would anticipate the treatment progress, as you can see here. And so when we take off the facial scan, what you see is just the teeth, and we can go through that animation here. And of course, at this level, we can evaluate occlusal contacts, the occlusion itself, and how teeth should be fitting. But when we go back into the position relative to the face, I want to point out something that I think is really important, because as we go back here, what you'll notice is, in a sense, I've almost taken him from a position in which he had a reverse smile arc to a position where, although I like the smile arc, he's probably showing a little too much gingiva. And so what we can do is we can go in, we can evaluate relative to the face again, how we want to move the teeth. And do we want to move things more gingivally in this case by moving the tooth up? I'll bring that off so you can kind of see the difference in how that would play. Or do we need to go to those central incisors and say, hey, both of these teeth need to be moved more gingivally because now we're just showing too much display of the gum tissue. And so this is something that is so powerful and something I think that we're all going to want to use in the future, because now what we're analyzing is more than just the teeth. And that's the power of the LightForce setup, and why we want to use this for our patients, because it really is the best thing to use to get the best possible treatment. So again, when I take this off, you'll appreciate where these teeth are now in the mouth. We're going to go ahead and put brackets back on and animate. And now I think we recognize that this is exactly where we want to be. And when we were looking at a reference, when I drew that occlusal plane line on our lateral ceph, we were looking at realistically the upper right 4 and upper right 5 hitting right on the plane. So again, you'll notice that there's not a whole lot of movement there with those teeth as far as their vertical position, but certainly a lot there in the anterior.
Thank you, Dr. Davis. Those are incredible patients and incredible progress. And thank you again for being a big part of the development here at LightForce. want to thank Ortho Practice US. It's been a crazy time for us at LightForce, and huge honor having Dr. Maz on the cover with LightForce as well. That was a big deal for us, and we're excited for AAO this year. We'll be there in our new headquarters, and if you get a chance, go to www.lightforceortho.com/AAO for updates on what our activities will be at AAO, and we hope to see you in Boston.
Thank you, everyone, for your questions, but we've run out of time today. So if we did not get to your question, we will answer it after the webinar via email. Be sure to take our free CE quiz associated with this webinar. Shortly, we will send you a recording of this presentation and instructions on how to access the CE quiz. Thank you all again for attending, and a special thank you to Dr. Maz Moshiri, Dr. Alfred Griffin III, and Dr. Blake Davis, and our sponsor for this webinar, LightForce Orthodontics. Thank you and have a good day.